for today's vertical integration session, Shattered Minds, Resilient Souls with Dr. Gordon Lau. Now, my name is Sydney and I'm from the PHN Education team. Before we begin this session, I'd like to acknowledge the traditional custodians of the land that we live and work on. For myself on the Central Coast, that is Darkinjin land, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about this session. We are recording it and it will be available for you to view in our education library in a few days' time, as well as a copy of the PowerPoint slides in PDF only. If you have any questions throughout, pop them in the chat. We're going to do a few pauses throughout so we can make it as interactive as possible. And at the end, I'll pop the QR code and the link for our Slido evaluation. Your feedback is extremely important as it helps us pick out these future sessions for you. Now, I will hand over to Dr. Gordon Lau.
Thank you so much, Sydney. I always feel strange being called Dr. Gordon Lau. Goodness, it sounds way too formal. But yes, okay, so thank you so much for having me this morning. And on an average fortnight, you can find me in all four of these places because I am crazy. I love working in different places to keep myself engaged and stimulated that way. I too want to acknowledge the traditional custodians of the lands that we're on. I'm zooming in today from Darkinjin land, and I also want to pay my respects to the elders, past, present, and those who are emerging. I also am committed to diversity and social inclusion. Therefore, I want to also extend a warm welcome to all those who identify as being gender diverse, people of all ages, disabilities, and also those who come from culturally and linguistically diverse backgrounds. So let's get into it, shall we? So this morning, my presentation is called Shattered Minds, Resilient Souls, a brief look at PTSD, otherwise known as post-traumatic stress disorder. Here are our outlines. So we've got two learning objectives. So learners should be able to recognize and assess PTSD and also be able to outline some treatment options for PTSD as well too. Now, I do recognize this is quite a tricky and quite a difficult and heavy topic. So I want to just extend a little disclaimer at the very start here to you all to that I do acknowledge that this is a tricky one to talk about, and sometimes we might have had our own personal experience engaging with trauma or having patients or people close to ourselves, people like family members or friends who may have actually engaged with trauma in the past and therefore may actually be triggering different kind of emotions in yourself. If I do so and trigger any negative emotions or distress in any way, I do want to apologize in advance. I'm going to start with a little case study here. This little vignette based on one of my old patients who I actually looked after in the past and loosely based on their story there. And it was when I was working in STARTS. For those who may not have heard of STARTS, STARTS itself is a service for torture and trauma victims. And I was working in that unit back in, oh goodness, almost a decade and a half ago now, over in Auburn. So at the time, we actually had a lot of refugees coming to Australia from different parts in Africa, but also in the Balkans when the Yugoslavia separated into different countries. So Marco is the name I've given to my patient, and he is a 43-year-old refugee who was conscripted to the army during the country's civil war. He's been struggling to adjust to life in Australia since arriving about a year ago with his wife Yelena, who's 40 years of age, and his daughter Danica, 10 years of age, and he continues to have a hard time with his English. He comes in seeking help. He got a job packing alcohol in a local factory about a month ago. Last week, a fellow worker accidentally knocked over a case of red wine, and the red liquid spreading on the ground gave him flashbacks of his fallen comrades from the war. He broke into a cold sweat and could not breathe. He stood there, frozen, as he watched the red puddle grow. He knew he just had to get out of there. So he ran through the emergency doors, setting off the alarms, and just kept running till he got home. He have not been able to go back to work since, and his bicycle is still there. A lone tear slid down his face as he trembles. In a shaky voice, he asks, "What's wrong with me? I'm fucked." So, with that to set the scene there, I was wondering, who's looked after someone who's experienced trauma firsthand? I'll get you to use the reaction button there. You can smash the thumbs up button or any other icon you want to use there. The teary face icon if you want to aim when you want. I want you to smash that for me and show me some little reactions there. So I think most of us have actually encountered someone in our clinical practice who may have actually experienced trauma. And I'll get you to do this again now and see if you've looked at someone who experienced vicarious trauma. This is when you have someone who didn't actually experience trauma directly, but was looking after someone else, and therefore in the process of doing so, was traumatized themselves. Have anyone actually seen someone who's experienced some vicarious trauma? Because this is a very common one for a lot of us as healthcare workers in the community who may have had patients who have gone through something traumatic. Yeah, I can see a few people reacted to that too. Sure. And my last question here as well too on this slide is, who felt out of their depths or unsure about how best to manage the trauma? Because I have definitely been there myself. I've been unsure about, oh my goodness, what do I do? Okay, where do I actually go from here? So hopefully today's presentation will give you some ideas about what things we can try, what's actually out there, what's evidence-based as well too, and be able to help to share some ideas that way. The thing though is that I know we've had a few chats about trauma over time, both in his vertical integration sessions, but also other teachings done with the PHN crew in the last few years. So I'm just going to use a few little slides here to recap what we should already know and hope to extend our knowledge in this area. So I guess the first question is, of course, what is trauma? Because when we talk about trauma, we need to be able to identify it and be able to have an idea about a concept of what do we actually consider as trauma, right? So trauma itself wise, I think this is one of the best kind of definitions that I found thus far and one that I love using. And it is where trauma is an emotional, psychological, and physiological response to a distressing experience that overwhelms a person's ability to cope. And I really love that because it really takes on the whole biopsychosocial aspects of ourselves as human beings and helps us to understand why do we have so many different kind of aspects to the trauma and so many things to be linked back to the trauma itself to then help us to conceptualize that in that way. The interesting thing though is that there's actually a difference between trauma as an exposure, because a lot of people say, oh, well, if I've experienced trauma, do I not instantaneously get affected by it? And the answer is no, because we see as well too in the community, many people who might have actually had many different traumatic events in their life seem to come out of it unscathed. So the most important thing here is actually our response to trauma. When we actually are responding to trauma in a positive manner and we actually work through it and then come out on the other side with a lot of support and help from those in the community, we tend to do okay. However, if we actually are responding to the trauma in a less optimal way and therefore continue to have these deeply disturbing events bother us and continue to impact us negatively, that's where we actually make these adaptive or traumatic responses. And that's what actually then impacts us in the future. So therefore, trauma is not just a single event that took place someplace in its time, in the past. It is actually also the imprints left by the experience on the mind, body, and also the brain as well too. And therefore, as a result, it then impacts on everything else that we do in our life. Question is though, um, how common is trauma? And according to the stats in Australia, 2 in 3 Australians will experience at least one traumatic event in their lifetime. Most commonly, people think about trauma as your serious accidents or attacks, natural disasters, famine, war. Okay, these are the things we often think about, right? Even though in Australia, we're actually quite lucky, we don't often get wars coming to our shores. But we do most definitely have our troops, for example, being deployed to war-torn areas for peacekeeping or otherwise for combat services as well too. One of the other kind of big areas would be, of course, our adverse childhood events. And these can be loosely grouped into 3 main groups: your abuse, neglect, and also household dysfunction. And in this group, this is actually the single most preventable group there in the community that we can actually do something about to avoid this impacting those in the future and therefore adding to one's trauma. Almost everyone who experiences trauma will be emotionally affected at the time, but based on our response in different ways, the initial experience of fear, sadness, guilt, anger, or grief usually fades with time and normally over the days or weeks after the trauma have occurred. Um, and as we start to make sense of everything around us and we actually have our distress level from this high level initially, come back down to a more manageable state, we then actually are able to move forward and no longer have the trauma there really impacting us negatively in that way. However, some traumatic events themselves can lead to other mental health issues impacting all aspects of one's life. And most commonly, of course, this will be your depression, anxiety. People might actually slip into alcohol and drug use as a way of self-managing or coping, and other kind of negative impacts and influence all aspects of their life, including relationships with family, friends, and their workplace, and the greater community as a whole. Overall, women themselves are a little more prone to traumatic events than men are in the actual ratio of 2 to 1, and age-wise, it can affect any person of any age group. Okay, whether you're a little child or all the way up into your senior years as well too. If we're looking at the actual overall amounts in our first responders and veterans, I think it's important to actually understand that about 1 in 10 emergency personnel have symptoms of PTSD. So when we're looking at the stats here, these are stats themselves from the Bureau of Statistics and also the Black Dog Institute. And you can see here that employees themselves have slightly higher rates of PTSD than we actually have in our volunteers, in our first responders. And that is for our anxiety conditions, depression, as well as PTSD as well too. And the main reason why there's a split there is because most of the time for employees, this is their livelihood. And so they often stay in this area for longer than they should be, and therefore gets impacted by a whole lot more of these traumatic experiences. Whereas volunteers themselves will often self-select themselves to go into and can also leave the actual first responders group at any one time, should they choose to do so. And therefore don't tend to be as heavily impacted. But that being said though, compared to people in the general population there, these numbers themselves are still higher than the average person in the community. If we are to break down our emergency services into our police, into our fire rescue, ambulance, as well as SES, you can see that they actually do have different rates in the different areas, all purely based on what different kind of cases or situations they may find themselves in or maybe responding to. So that's the reason why we do have a difference in the different groups of our emergency personnel. Sadly, though, most don't seek help until it's too late. In fact, when we actually go, by the time that people do seek help from our emergency service workers, suicidal thoughts and planning were estimated to be about twice as high as the actual counterparts in the community who are not in first responder roles. So the other part of the heading was talking about veterans. So where do veterans sit in this grand scheme of things? And you can see here, veterans themselves definitely sit a lot higher. And the sad thing is that they may be actually explained by cultural reasons. So many ADF personnel often would hide their mental health issues, and including admitting this to the ADF, because if they did do so, they would not be able to be deployed. And they often would reveal symptoms much, much, much too late when they cannot hide it anymore. There's also a big culture of alcohol use and other substance use as well too to cope, and often seen as a sign of weakness when they actually do admit to having troubles with their mental health and well-being because of what they have experienced in their life there. So that's the reason why there's always going to be a higher number of people in the actual defense forces who may be suffering from mental health conditions and issues, but not actually have fronted up for care or help. And therefore, when they do come to us as doctors or other health professionals in the community, it is extremely important for us to really take them seriously and really give them the support that they deserve. So I'm just going to play a little video here for you to actually help you understand a little bit more about trauma. Should be loading up soon.
There are moments in life that test us. They challenge our understanding of the world and our sense of safety. Natural disasters, accidents, violence. These events can come from nowhere, or they may have always been part of our life. Trauma comes in many forms. It affects thousands of Australians every day, people from all walks of life. The ripple effects of trauma impact everyone. After a traumatic event, the world can feel unpredictable and unsafe. For most people, this feeling passes with time, and with support from loved ones, life goes back to normal. But sometimes it's harder to get back on your feet. Fear, sadness, guilt, and anger are all common reactions. But when they continue for too long, they can leave you feeling helpless and exhausted. Distressing memories, images or sounds may replay over and over in your mind. The effects of trauma start to creep into everyday life, affecting relationships. You may even pull away from important relationships and activities. You may have trouble getting a good night's sleep, and sometimes it can be tempting to reach for alcohol or other drugs. It can feel like you're on a treadmill, not making any progress, and you don't know how to get off. You're left feeling overwhelmed and trapped, and your family and friends feel helpless. But there is a way out. Effective treatments and support are available from professionals who understand trauma. You can get your life back. For information about recovery, visit phoenixaustralia.org.
So that little cute little video there, I really love because it really encapsulates so many aspects of like trauma and the traumatic experience there, and be able to actually put some words to it and be able to help us out. So I was just going to say, I do have any questions at the moment, because before we actually dive into more of Marco's story.
We've got Subashi's hand up.
Yes, Sabashi. I can ask a question, or was it actually right?
No. Sorry, Gordon. I just had my hand up for that reaction before.
That's okay. No problems at all. All good. All good. Well, if there's any other questions we have at the moment before we go? No? Let's keep on moving then, shall we? Sure. All right, then. Let's get more of Marco's story. So, Marco asks, what's happening to me? I thought things would get better coming to a safe country like Australia. It's been almost a whole year now. Why is this still happening? Given his history of fighting in the war, you think he might have PTSD, post-traumatic stress disorder. The question is, what else would you like to know to confirm his diagnosis and his impact on his life? And also, do you think he would benefit from some psychoeducation? How would you help Marco make sense of his presentation? So in the chat box there, I'll get you to put your answers into what else you would like to find out or to actually confirm the diagnosis. And whilst you're doing that, I'm going to lead you into some kind of like psychoeducation here to understand what is actually happening in our brains and why is this trauma, how does it continue to impact us in this way? Okay, so please send through your thoughts in the chat box for what else you would like to know to confirm his diagnosis and its impact on his life. So I think whenever we talk about anything like trauma or stress, anything like this, we often talk about a stress response, and everyone talks about, oh yes, back in the caveman days, okay, and we actually have things like a threat come in and disturb our sense of self and safety in the community. So if you actually had your home, you can see there a small little rocky hut, and have a saber-toothed tiger outside your front door, what do you actually do? Okay, so it's important for us to remember that our brain is a problem-solving machine designed to keep you safe. So therefore, it actually takes the actual input, what's happening around me, and then generates a list of probabilities and say, okay, well, what am I going to do as an output here? What's going to be a safe thing for me to do? How do I manage the scenario or the situation that I find myself in? And based on that, our body itself would then actually have the different responses, these instantaneous responses here. So we often call this our fight or flight responses, which is when we actually either stand our ground and fight off the saber-toothed tiger, or we actually flee and run. Hopefully we can outrun the saber-toothed tiger. And our brain, because it prefers to keep ourselves safe, we will often choose these two options there as our preferred choice. Because if we can do that, then we can say, you know what, if I survive this, I can pat myself in the back and say, well done, I did a good job, I kept myself safe, I kept my community safe, yeah, I triumphed. Okay, so that's how we will often prefer to be. However, these are not the only two responses we can have. We can also have a freeze response, where our body becomes frozen with the fear there, and we can't move, we can't fight back, we can't flee, we can't do anything, and our body goes into shutdown. And when that happens, that immobilization of our body itself is the actual root of all trauma. Because when we feel unable to make a difference, to actually make the situation less traumatic, we then actually lay there frozen, and after the actual events have actually occurred and the fear and the actual distress and the danger have subsided, we actually then actually blame ourselves whatever consequences happened, because it's that I am so useless here. I was not even able to do anything to stop my attacker or do anything to fight back. I am a useless person as a result, and therefore that then reframes ourselves and our opinion of ourselves, therefore making this traumatic response even more pronounced and more ingrained in ourselves that way. And we see this a lot in our our survivors of sexual trauma, for example, or survivors of assault, where the person felt completely powerless to fight back. And therefore, the actual trauma becomes much more ingrained. I think it's also important there to understand different parts of our brain and why do our actual responses occur the way that they do. So here's a little video for yourself talking about the different parts of our brain. So this is presented by Russ Harris, one of and on Dan Siegel's hand model of the brain. Come on.
So let's just go through it again. You've got your spinal cord, you've got your reptile brain. Underneath your cerebral cortex, you've got your mammalian brain with the amygdala, the hippocampus, responsible for emotions. And then you've got your cerebral cortex, your thinking cap of the brain on top, and the medial prefrontal cortex right here in the center of the front, right there.
Okay, so with this model here, so let's there. Yep. So this model here. Oh, come on, you can do it.
So let's just go through it again. You've got your spinal cord, you've got your reptile brain.
So you can. Oh, far out.
So let's just.
He doesn't like me. Technology, the joys.
So let's just go through it again. You've got.
So yeah. So you see that. So looking at the actual the brain itself wise. In this brain model, using the hand to represent different parts of the brain itself, when we are actually stressed, when we are actually feeling overwhelmed, our thinking cap on the top there, that actually stays on the top to actually control everything below it and sending feedback to everything below it is no longer engaged. So all you have left is, when you flip the lid, all you have left is your reptilian part in your brain there, which does your automatic responses for survival, and your emotional aspects of your brain there, which is on the thumb, which is the amygdala here in this model, ruling the whole processes, all the processes in your body there. So therefore, instead of actually thinking things through with your thinking cap, the thinking cap is now offline, and you are now basing all your decisions on your emotions and your survival in here. So as a result, we tend not to think things through. We don't tend to integrate the information that we have got around us. And that's the reason why we will often have a harder time coping with the different things life throws at us. And that's the reason why we then actually have this impact. So as a result, the actual impact of trauma on the brain is that the thinking center becomes underactive, and that's our prefrontal cortex here in the frontier of our brain, and therefore all that executive function goes offline. and we can't weigh up our pros and cons and be able to do all the complicated stuff that we would normally do in our everyday life. Our amygdala, for our emotion regulation center, is also underactive because the fear center have taken over, and it's now becoming overactive, and we were judging everything based on emotions, and anything we can do to aid our survival, we will do so. And the hippocampus there, in part of your actual brainstem there, for memory center, for our contextual memory is also then faulty as well too. And so as a result, we have a very hard time acknowledging the fact that the actual threats have been neutralized and that we actually don't have a sense of safety. And as a result, we continue to go in a spiral, going back round and round in circles, continuing to keep us in this perpetuated state of fear and distress, resulting in our hypervigilance, resulting in our kind of distress there, continuing from day to day, flooding into all aspects of our life. So therefore, everything that we see gets superimposed by the trauma on and everything else around us. Talking about our adverse childhood events, I know this one here was a topic that was beautifully presented by one of our registrars recently. So Dave did a presentation on this last year, talking about our adverse childhood events and how they impact on ourselves in the future. And we can see that these three groups, our abuse, neglect, household dysfunction, all of them actually are experienced by people in the community. In a decent number of people in the community will have this experience of these three things. Two-thirds, just over two-thirds of the population will have at least one of these adverse childhood events, and 16% will have 4 or more of these adverse childhood events. And as a result, they do result in some neurodevelopmental changes and epigenetic changes, causing ourselves to have our maladaptive coping mechanisms to manage the dysregulated level of arousal. And as a result, that can impact our behavior and physical health as well as our mental health and well-being. To the point where when you actually have 4 or more ACEs, we will have about 3 times the level of lung disease and adult smoking compared to the average person in the community, 11 times greater level of IV drug use, 14 times the number of suicide attempts, as well as 4 times the likelihood of sex before 15 and other risky behaviors, 4.5 times more likely to develop depression, and 2 times more likely to have liver disease due to our traumatic experience in the past. You can see that it's not a small kind of a problem at all. Furthermore, okay, remember how I said before that our trauma then finds a way to superimpose itself on everything we do in our everyday life and how we actually see the world around us, how we relate to those around us as well? Well, therefore, it actually impacts on the way we actually make relationships. When we actually have a person who is well-adjusted and actually feels assured of themselves, their inner child feels safe in the community there. And I love this little picture because I think this is a beautiful way of describing what we're seeing in the community around us. But when we actually have experienced trauma and we're unsure if things around us are actually out to get us or not, that's when we actually have troubles. And therefore, we constantly going to be overwhelmed, distracted, which then leads into our reduction in our ability to learn, and our behavioral problems themselves often becomes more exaggerated, resulting in poor academic performance. But also, so too, we tend to then shift more into our compensatory responses, leading to our once again, our actual dysregulation there, resulting in poor productivity, absenteeism, and burnout. And that's the reason why trauma is such an important thing for us to acknowledge and be able to manage and be able to actually offer help if the person is keen for it as well too. So now, this then comes to my next point. Have we all been sending our responses through into our chat box? So what other things would like to find out about Marco? Because I'm keen to find out what you would like to find out from Marco to be able to work out, do I actually rule in a diagnosis of PTSD or not for him? How do we go?
Yes, there's a lot of responses. Can you see the chat box, Gordon?
Let me have a look.
Yeah,
I was trying to load it up right now. Give me 2 secs.
Yeah. Yep. Otherwise, I can read it out for you.
Yeah, sure.
Yep. So there was duration of symptoms, other flashbacks, explore symptoms of intrusive thoughts, hypervigilance, and avoidance.
Yeah.
asking about the presence of nightmares, flashbacks, triggers, alcohol and drug use, explore comorbidities like depression, poor appetite, any pleasurable activities, diurnal variation in mood. So physical symptoms related to stress, pain, exhaustion, reflux, bowel symptoms. Also suggestions of, obviously doing a full mental health assessment, doing the physical checkup as well, assessing psychosocial supports.
Yep. Beautiful.
And then Sebastian's
That sounds
got some
great.
great responses. Yeah, obviously engage, explain confidentiality, get him to tell you his life story, ask specific questions of diagnosing PTSD, and the most important thing, congratulate him from coming in.
Yeah.
And explore other trauma, family dynamics, support systems, and previous medical management. So some
Absolutely.
great responses.
Can I just say a very big thank you for whoever posted, congratulate him for coming in to get help. And I do this all the time with my patients, and I actually, thank them for having the courage to come in to actually seek further input, because it is quite a scary situation where we don't know if we can trust our own emotions, our thoughts, and our behaviors themselves scare us as well too, and those around us. And it's really important for ourselves to acknowledge how much courage it actually takes for someone to come and seek help for themselves. So well done indeed. And I love those responses themselves, and these are exactly what I'm looking for. So well done. So it sounds like you all know a lot about trauma already, which is awesome. So let's kind of dive into our next slide here, because I'm going to outline a few things here for yourself. So this one here is a quite little mnemonic which you can use to help you understand the different aspects that we want to look at for trauma, and therefore do we actually have enough there to actually then diagnose a person with PTSD. There's actually two different disorders on the DSM criteria that actually talk about trauma. We talk about our acute stress disorder, which is exactly the same in this presentation as our PTSD. The only difference, though, is the time frame and the fact it does not require a cluster of symptoms to rule in. So you can see here that for acute stress disorder, it must be diagnosed within the actual 2 days to 1 month of the actual traumatic event happening, but it should actually then completely resolve within that time. If it does go beyond that, though, for more than a month from traumatic events, and also having symptoms to satisfy the 4 clusters of symptoms required to rule in our PTSD, then of course we have an increased level of likelihood. And I say increased level of likelihood because we still have to understand that we need to have this impacting a person's everyday function. If you wanted to look at the DSM-5 criteria in full, this is what it actually would appear like. And you can see here, I put on the sides there for you that we have to have 1 or more, or 2 or more of the different ones here to rule in the diagnosis of PTSD. You'll have this as well too. I know it's very small on the screen there, but you'll have this in your notes when you get them after the presentation. So when it comes to assessing PTSD, you can also use checklists themselves to help you out. These are not actually to rule in something completely, but the thing is, it helps you get a better understanding of if this is a likely diagnosis or not. We're not here engaging in checklist medicine as such. So therefore, your PTSD checklist, the Phoenix Foundation and also the Black Dog Institute both do recommend using the PCL5 checklist. And if you are looking at dimensions of anger reactions, because anger and frustration are often things associated with PTSD as well, you can also use this other kind of checklist here to help you see and quantify how often does a person actually shift into anger when they actually have this presentation. So back to Marco. So Marco tells you more of his story now, and you get to find out more about what happened. So Marco tells you that he lost most of his battalion when the coffee shop they were at was hit by a missile attack. Hence, he cannot stand the smell of coffee or meat on a barbecue and avoids them both at all costs. He also has recurrent nightmares of his comrades and wakes up in a cold sweat each night. Once awake, he struggles to get back to sleep. He rarely leaves his home. Although he knows it was the right choice to come to Australia for his family, he has an immense sense of guilt for leaving friends and his extended family behind. He reports he often feels emotionally numb and have lost pleasure in all things he used to enjoy. Last week, Danica, his daughter, scared him on purpose. His initial startle response quickly turned into an uncontrollable rage. He did not hit her, but his screams at her ended with them both crying. He had yet another big argument with Yelena, his wife, the other night because because she's fed up with his angry outbursts and told him she no longer recognizes the man she had married. You did his PCL-5 checklist, and he scored was elevated, consistent with PTSD, and his DAR-5 score for his anger assessments was sitting at 15, which puts me into the high range as well too. So, with that presentation there, I think it's pretty clear that he does have features of PTSD and he's definitely struggling with it. But the thing though is that what else do we need to rule out? Because PTSD can also, PTSD-like symptoms can also occur in other mental health conditions. So things like anxiety, depression, substance use disorders themselves are often comorbidities linked with our PTSD. But also, so to differential diagnoses, things like your personality disorders, your trauma-related disorders, somatoform disorders, as well as our dissociative disorders are often differentials for us to consider. Another one that I was going to show you here in the little diagram is that it is important for us to remember that PTSD is not the same as complex PTSD, and it's not the same as borderline personality disorder. Even though they do share commonalities between them, they are not the same and they're not synonymous. So please avoid making that mistake. If you do want to find out more about this, there are some great resources I can point you to in the future. So, then of course, leads us to question, how does trauma present? And we can often see that the body keeps a score. And this is actually the title of the book where I showed you from the very, very first slide there. We saw a gentleman by the name of Bessel van der Kolk, which I didn't actually introduce him at the time, but he is he's a specialized trauma psychiatrist who works over in Boston, Massachusetts, over in the States. And he actually wrote this book, was a landmark book in trauma because it actually details his learnings from what he actually did with a lot of the actual veterans who came to the hospital he was working in, and how they actually looked at different ways of managing trauma and what he's learned from the experience. Really great book. He's also a really engaging speaker. If you ever get a chance to see him talk, or otherwise look for different videos of himself presenting his little sessions on YouTube, he is gold. So you can see here that a lot of the times there, we will have physical ailments themselves as an expression of the mental distress and trauma that we experience. And these kind of cells can also be quite different comparing our adults presentations compared to our children presentations as well too. So you can see here that these are the common things we'll be looking for in our adults compared to children. But what we're seeing here is, if you were to sum it up, a lot of chaos in their life there because of the actual consequences of the trauma and all the trauma adaptations as a result of their actual experience that way. So, yeah, let's keep moving because I know we're running low on time. So, as I promised, and our second part of our learning objective is looking at management. So, and I put this in here too because we often use the actual myth of the phoenix being able to actually help people to instill a sense of hope that we can actually rise again, and we will often be bigger, stronger than we were ever before. And that's often then used as a symbol of our clients triumphing over their trauma. There's a lot of mention about psychological first aid, and this is actually a cool little way for us to conceptualize trauma, what we can do as people in the community. And there are actually a lot of courses available to teach the general public. It's kind of like our mental health first aid, like our actual physical first aid we do for people in the community who might have injured themselves. This is for our psychological trauma, of course. And we actually have this based on 7 principles of care, protect, comfort, support, provide, and connect and educate the person. And of course, the whole time we're doing this, in the 7 different principles of psychological first aid, we as a person who is trying to instill these things in those around us, we need to also take care of ourselves as well too. But you can see here that all of these principles of psychological first aid are based on the core principles of trauma-informed care, which is a strength-based framework which recognizes the complex nature of how our trauma impacts on ourselves and the importance of how we can actually address the trauma to promote resilience and healing. And in trauma-informed care, we actually base this on 6 core principles. These are safety, trust, choice, collaboration, empowerment, and respect for diversity. If you want to find out more about this, you can also go to a previous presentation we have done through the PHN on this topic that I've delivered last year, I believe. So yeah. But okay, at the end of the day though, the aim is actually very simple. Oh, simple to put it on paper. Okay, maybe a little bit more difficult to execute. The idea of why we actually do this is because we want to help to shift a person towards this post-traumatic growth and be able to also help to instill hope in the person as well that we're working with. So back to Marco. You thank Marco for disclosing their trauma and determine that he is motivated to learn how he can better manage his trauma. And it's really important that we should use our stages of change model here as well to then work out where a person is and be able to understand what we can offer as a health clinician to support them in their journey of managing their trauma. So you take a trauma-informed approach as you provide him some more psychoeducation about his trauma, and he actually asks a question: what do I need to do to get better? How would I even know if I'm better? And that's actually an interesting question that we often do here. How do we actually know? And most of us don't often get to ponder that question ourselves, do we? So I've got a few little answers here for you to help us to conceptualize a few things. But before we do look at these two questions, does anyone know what this kind of art form is from the picture on the side? It's a Japanese art form, and we often see this come up when we're talking about trauma. Does anyone know what it's called? Shout it out if you do. The thing though is that this art form here, you actually...
Ikali.
Okay, what's that, sorry?
Ikali?
Not Ikali, no,
where
not
they
Kintsugi.
They put the gold where it breaks.
Yeah, Kintsugi, it's called Kintsugi.
Make
so,
it
yeah.
stronger.
Yeah, so yeah, it's actually right. So what you do is you fire the actual pottery piece, you then break it on purpose, and then you actually glue it back together with gold lined in the actual the glue there, and you therefore make it even more beautiful than it was before. And you see the actual and you embrace the imperfections and recognize that it is actually perfect the way it is, with all the actual fractures, all the breaks, and all the imperfections that we are embracing as a whole. So yeah, so it's a really beautiful kind of art form, and often have been adopted as well in a lot of trauma-based works as well. So so when you are healed, so when are you healed from trauma? I think that this is the words I often use to describe it: when you don't have to rely on your trauma-related coping strategies anymore, and you are able to integrate your memories and your body sensations, and you make them your own. So how do we actually do this? Okay, how do we actually manage a trauma to help a person heal from it in that way? You can work from a top-down approach or bottom-up approach. Remember, when we actually have traumatic events there, we often try to separate what actually our mind is actually thinking and our emotions from our physical body itself. Because what we actually know is that in that actual situation, when we are being traumatized by things around us, we would often feel the pain so much more if we were actually being very present in that moment and were connected. So we have learned to separate the two, and we then actually struggle with this mind and body divide. If we are to get a person whole again, we need to then reintegrate the mind to the body and be able to connect the two parts back together, and therefore be able to help them in that process there of doing so. And there will be a lot of fear in that process there, but it's really important for our trauma healing. You might actually also be asking, so where does medications come in? Medications themselves only really help as an adjunct to help to reduce the symptoms of PTSD, to allow the person to do the important work with their talking therapies to help them with their actual mind or body focused approach to then reunite the different parts of themselves and reintegrate themselves that way. So it is important for us to actually understand that. And for a person who actually have experienced significant trauma, we need to actually stay flexible and we need to be actively engaged in our trauma healing. And it's a lifelong journey for many of us to actually go on. So what can we actually use to help us out? So here are some little flow charts to help you out. So this one here is from the Black Dot Institute, talking explicitly about PTSD in our emergency service workers. And they actually promote the use of EMDR at a very early stage. And that's a flow diagram we go through afterwards. As for the actual Phoenix Foundation, they look at a different algorithm for medication prescribing, because if we did need to give medications, they often talk about our first line being our SSRIs. Then we actually add on our we switch the actual SSRIs to our SNRIs, the venlafaxine, for example. And then we can have more of our adjunctive therapies there on top of that as well too, to then help to cope with different aspects there. One of the ones that I was going to highlight here for yourself is our the use of prazosin. Prazosin self-wise is an alpha blocker used as I know it was created as a blood pressure medication, but it was also found to be really good at calming the mind, and so therefore it can be actually helpful for intrusive nightmares a person may experience at nighttime. I was also going to spend a little time talking about different kind of psychological inputs, because I know a lot of the times there we kind of say, yep, I'll refer you to a psychologist and say goodbye to you kind of thing and let them do all the hard work. But many of us don't often understand the different things that it can do. So that's why I thought I'd mention EMDR, which I mentioned in the previous slide. EMDR itself, it actually stands for Eye Movement Desensitization and Reprocessing Therapy. And what they do is that they actually realize that when we are in a dream state, our eyes themselves will often be beating and moving in a certain kind of frequency. And that's the reason why it is important for us to use that knowledge to help us to reprocess our memories. And we found that when we are in a dream state and we emerge from our dream, we often know that it's a dream and therefore we don't get too overwhelmed by that. But the thing though is that if we are able to then use the same kind of state in our alert state there to re-engage in that movement, we can often then recall our more painful, distressing memories and still use the same kind of eye movements to then sort and put it into the rightful place, and therefore be able to have less distress when we're engaging in that process there. And that sorting and putting in the rightful place is what we mostly have troubles with, because when we have traumatic events, these are unpredictable things that just happened and scared us and frightened us. And our poor brain, which is trying to do all this work to integrate things in the rightful place, has a hard time doing so. Therefore, the traumatic event continues to stay in the inbox, yet to be processed, and continues to be reminded by that, say, yep, still in the inbox, still in the inbox, still in the inbox, still yet to be sorted out. So that's the reason why EMDR can be useful in this way. CBT, of course, everyone here knows about CBT, but we actually are looking at addressing our events based on our thoughts, and knowing how our thoughts impact our feelings and emotions, and how our feelings and emotions impacts our actions that we take, and how our actions are then going to be judged by our thoughts, and round around it goes again in that way. So that's how CBT works in a nutshell. And from CBT, in more recent times, we have then actually formed ACT, which is your acceptance commitment therapy, and we look at a hexaflex model. So we can look at our values, committed action, experiential acceptance, cognitive diffusion, present moment, and self as context, and using this kind of hexaflex there to actually wrap around a person. And I personally quite like this because it is more flexible and it can shift between the 6 points there depending on what the patient needs, and transdiagnostic as well too. If you have a person who's having a lot of troubles with their emotional regulation, your DBT, dialectical behavioral therapy, which also came from our CBT grounds and roots, would be a good option there to consider. This one here actually works on 4 main elements, looking at incorporating our mindfulness, emotional regulation, distress tolerance, and interpersonal effectiveness to help people work through different aspects to improve the ability to communicate to those around them, engaging with those around them in the future, but also so to bring down the level of distress to a more manageable state. Schema therapy itself wise, it looks at the different unspoken rules that we have in our brain there through our experiences in life and how we then see the world around us. And if these rules themselves that we've written for ourselves to abide by, if they were actually somehow faulty or inappropriate, how do we go through and adjust and tweak these schemas or these rules or these algorithms to then help us and have more appropriate functioning in the community? So that's schema therapy, and it's really helpful also for trauma. If the trauma itself was based on more of an interpersonal conflict, your IPT can be helpful. This is for interpersonal therapy. And in this situation here, you explore your interpersonal challenges and scrape for presence in grief, managing role disputes, or facilitating transitions in roles that we're not comfortable with. So change, for example, is a big area looked at here. This one is one of the newer ones out there, internal family systems, and it's looking at how do we actually activate yourself and different parts of yourself. So sometimes you might actually have yourself as the actual vulnerable person inside there. There'll be parts of yourself coming forward as the how do we actually encourage ourselves to get the actual courage to then perform and fight off different kind of things around us. Who actually how do we actually and evoke different parts of ourselves there to manage our emergency responses? How do we actually do other things to help to keep ourselves safe? So we talk about ourselves, managers and firefighters and exiles in this actual process here, for that all are different parts of ourselves that make us whole. Others side of things wise, I put down there psychedelics because I know it's getting a lot of attention recently, and psychedelics themselves wise have been used over in the States a bit. In Australia, not quite so much, but we're trying to do more research at the present moment in this area. So if you were using your psychedelic assisted therapy, you will have the psychiatrist who is engaging in therapy here to actually dose the person with a psychedelic agent. So it could be psilocybins like your mushrooms, could be things like your MDMA, and you will actually have a therapist there, a trained therapist who's just a psychologist who's there with you to join you on the trip that you're on. And they continue to actually chat to yourself and guide you through working through your different traumas that way as they get you to bring up these memories that you've been having troubles with and then help you to lead you down the right path to help you put this kind of trauma aside and be able to move forward that way. And when you then emerge from your actual trip, then kind of reintegrating and reflecting on the process there. It's to myself, it kind of sounds like the actual plot of Inception. Those of you who have watched that movie, so looking at how we can use dreams and other things like that to help us create ideas and put in ideas into people's minds through that process. It's kind of like that. But yeah, so other management strategies themselves wise, so these ones here are also found to be really helpful. If we are able to learn how to reduce our hyperarousal through medications, yoga, or communal bonding kind of experiences, like say rhythm and drumming can be helpful in that way. Mindfulness, which I'm sure people have heard about lots, and it's all about slowing down to bring self-awareness to how the body is doing when the brain thinks about the past trauma and how it will help to process the trauma better. Relationships is the key here. If you're able to actually maintain your connections with those around you, to find your own tribe, that actually helps to provide not only physical safety, but also emotional safety as well. Sensory integration wise, looking at our playing together in groups to restore attunement to life and self and others. Physical touch is another big one, and this is because it helps the person then relearns the fact that physical touch often actually being violated in their actual previous accidents or attacks or assaults is actually not a harmful thing, and it can actually then reprogram that, saying, okay, this is actually okay, I can reintegrate and know how it feels and be able to re-engage my thinking brain with my body and make myself whole again. And last but not least, taking action. So for example, if we are doing, say, acting kind of as a therapy, so taking on roles of people who actually are survivors and therefore triumph over their trauma or the attackers, or be able to actually learn self-defense to help you feel more self-assured that way. So all these things themselves can be of help. This is my last slide. So looking after you is really important. Whenever we as health professionals are doing any of this work, it is actually emotionally taxing work. Please make sure you do pay attention to your ABCs. And these are your awareness to your needs, your emotions, and your limits. Be able to balance your work, leisure time, and rest to help you recharge yourself, and making sure you do stay connected to those who you care about and something greater as well too. Taking topic further, the white book, of course, can be really helpful for us to explore this topic further. There are courses available, free courses like the This Way Up program. Oh, sorry, this one here is not free. This one here is $60. But if you are actually registered with This Way Up, you can then refer your patient to access this for free. Phoenix Australia and Open Arms and also Blue Knot are all three different ones here in Australia which specializes in trauma. But of course, as well too, knowing many of our Indigenous community do engage in trauma a lot, the World Mob team also have services there as well with more of an Indigenous focus. Bessel van der Kolk, which I mentioned beforehand, it's awesome. And I do encourage you, if this presentation has sparked your interest in the topic of trauma, to read his book or to listen to one of his presentations. And Gabor Mate have also been a very famous person talking about a lot of trauma topics. So a quick summary. Trauma impacts all of us. 2 in 3 of us will experience significant trauma in ourselves, but our response is the most important thing that determines the outcome. So it's really important for ourselves to know that trauma can be managed by many things. Helping to reintegrate our body and mind is actually the most important part, and medication are simply just an adjunct to help that process there. People who actually have engaged in trauma need to engage in the trauma therapies lifelong and be able to continue to do the work in themselves to help them through. And we as health professionals need to make sure we mind our ABCs to help ourselves to avoid burnout. So thank you. I took this time there. We're right on the dots. Any questions?
Thanks, Gordon. That was amazing. I'll wait for
Thank
Georgia
you.
to come back on as well because I'm sure she has something to
Yeah,
say. I'll let her go
my
first.
mouth wasn't working. So that was
I'll let you go
amazing,
first,
Gordon.
Georgia.
That was an amazing overview, and thank you so much. And we very much appreciate your special interest in mental health and sharing your knowledge with us as well. So that's some great resources there. So
Thank you.
managing a difficult condition. So, and I don't think any more questions there. So we've got lots of thank yous. So great. Very good. Thank you so much, Gordon. And in 2 weeks' time, who have we got in 2 weeks, Sydney?
Oh, God.
Oh,
Let me see.
quickly.
Hey, pressure. I'm usually really onto it. Let me just, let's see. Yes, tomorrow. Here we go. Dr. Lee Fong, we're doing artificial intelligence in general practice.
Oh, yes.
Yes, that should be a good one. So if you do have any questions for that, let us know. I'm going to say thank you, Gordon, and just stop the recording for today.
Sure. Thank you.